Now I'm going to give you a ridiculously quick intro to joint pathophysiology with particular emphasis on the arthritises, the arthritides, and tendinopathy. And we're going to try and get through this really quick. An arthropathy is simply any joint disease, right? And there's a tendency to think of it as inflammatory versus traumatic, right? So arthritis is nominally, if you look at the word, it means an inflammation of the joint. But what do you find when you actually look at arthritis, like osteoarthritis, right? Well, you find that you've got an inflammation of the joint, and that is a theme that I want to emphasize during this presentation. When I was in med school, I was taught, for example, that osteoarthritis was a completely non-inflammatory process and that the use of non-steroidals in osteoarthritis was inappropriate. Well, all that's wrong. In fact, there are no truly non-inflammatory arthritides, right? If you look at them, they all contain a component of inflammation. The arthritides include rheumatoid arthritis, which is an autoimmune inflammatory arthritis, septic arthritis, basically where your joint becomes a petri dish. Some of these other autoimmune and inflammatory arthritides, like those associated with lupus and inflammatory bowel disease, and the crystal arthropathies, which we will discuss briefly, like gout. We're not going to spend too much time on sprains, strains, fractures, dislocations, and so on. So here's a classical classification that you may have learned at some point in your education. You got your degenerative joint disease, which is your osteoarthritis, which is supposed to be non-inflammatory. Inflammatory arthritis like RA, Ankylosing Spondylitis, Reiters, and so on. Metabolic arthritides like the crystal arthropathies, hemochromatosis, hemophilia, and infectious, right? Again, where you have microorganisms, little bugs growing in your joint fluid. These are all inflammatory. If you look at them, you will find that inflammation plays a role in all of them. We're going to start by looking at the one that is supposed to be non-inflammatory, the wear and tear arthritis, osteoarthritis. How many have heard that term? Everybody's heard that term. Osteoarthritis is the wear and tear arthritis. It's a mechanical degeneration of the joint, right? We were comparing our numbers yesterday on epidemiology, and it kind of depends on who you read, but in general, you're talking about maybe 3 to 5% of the general population. If you look at people over 60, it's obviously going to be much higher. Increasing age and increasing weight are major risk factors for the development of this disease. Again, still thought of as wear and tear. It's actually multifactorial. Any damage to a joint will promote the development of osteoarthritis in that joint in the years and decades to follow. So preceding trauma is a major risk factor for osteoarthritis in any joint. Obesity is huge, but not for the reason that you think it is, right? Not necessarily for the reason that you think it is. Insulin resistance, morphological factors, so if, for example, if you have a deformed joint, like say you have a valgus deformity in the joint, or you have a shoulder that doesn't line up quite right because of a rotator cuff tear or something like that, that is a risk factor for the development of osteoarthritis, and there is definitely a genetic component. The presentation is crepitance, which basically a fancy word meaning a crunchy joint, osteophytosis, bone spurs, joint space narrowing, which we'll see on x-ray, decreased range of motion, swelling, effusion, which basically means water on the joint. Knee effusion is water on the knee. Joint disfigurement, particularly in the hands with osteoarthritis, pain, stiffness, joint locking or instability, and this is key, affective disorders go along with osteoarthritis. Depression, suicidal ideation, learned helplessness. Will's going to talk about that a lot. This is the radiographic appearance. I think that we can all see that these are two very abnormal joints here, right? And the knee, you see joint space narrowing to the point where at some points along there is no joint space. You've got bone on bone. You've got bone spurs hanging off the tibia, right, and off the femur here. And if you look closely, you can see that underneath the joint space, you have this enhanced density of bone, what we call the subchondral sclerosis of the bone under there. This ankle is similarly destroyed, and you can see some cystic changes, cystic degenerative changes in the bone there as well, where you've got the bone-on-bone component of the arthritis. That person does not have a normal gait. So, what is going on here? Good, you guys can see that pretty well. So we're going to look at what's going on in osteoarthritis. It's called a wear and tear arthritis. Okay, let's tip our hat to that. Let's start with wear and tear. Bearing in mind that the wear and tear doesn't have to be mechanical, right, as we will see. Anything that leads to any degree of destruction or damage to the cartilage matrix at all can initiate this process. So let's say we've got something that damages the cartilage, trauma, wear and tear, or some other process that results in the release of microscopic fragments of the cartilage matrix and or collagen into the synovial space. Just to orient you, this is bone down below with osteoblasts in there. The two blue layers on top of the bone are the superficial and deep cartilage with the chondroblasts embedded there, and you can see the synovial, the joint capsule and synovial membrane on either side, like big parentheses, and all that stuff in there where it says wear and tear, that's all synovial fluid. All right? So you have the release of these microscopic fragments of collagen and matrix into the joint fluid. Well, it turns out that these materials are highly pro-inflammatory, and they will induce a synovitis, an inflammation of the synovial membrane. They'll really piss it off, and a pissed off synovial membrane will respond with an entire catalog of pro-inflammatory substances, signaling molecules, cytokines, interleukins, interferons, complement, which is what your immune system uses to attack foreign cells, right? And various other substances that you don't want floating around in your joint fluid. These substances have a profound impact on the chondrocytes embedded in the cartilage matrix. And if we look at the level of the chondrocyte, what we'll see is that the chondrocyte has dedicated receptor and signaling systems that are able to respond to these substances, these pro-inflammatory substances released by the synovium. The synovium also releases complement, right? The complement protein, which initiates the formation of a membrane attack complex on the cartilage cell itself, right? It basically punches holes in the chondrocyte membrane and eventually can kill the chondrocyte. But before it does, the chondrocyte will respond to these various signaling inputs with a transcriptional response, an RNA response, an entire library of genes designed to break down cartilage and perpetuate the inflammatory response within the joint. And when that gene library gets translated into actual protein, those proteins are released into the synovial fluid where they engage in fuckery, right? They further perpetuate the inflammatory response, they degrade cartilage, and so what you see here is you start to close loops, right? More damage results to the cartilage, so you have more collagen and cartilage fragments in the synovial fluid, which perpetuates the synovitis, which just makes all of these sort of loops close themselves, and you've got these vicious cycles going on, right, within the cartilage fluid. In addition, the bone responds, right, with a number of signaling molecules and the elaboration of matrix metalloproteinases, which are very bad for your cartilage, and a number of other signaling molecules which will lead to osteolysis and further damage to the cartilage. You also get the response of what's called VEGF, or vascular endothelial growth factor, which can lead to neovascularization of the deep cartilage, blood vessels forming in this deep cartilage layer and subchondral bone layer where you don't want blood vessels forming, right, which further weakens the joint. And with the elaboration of tumor growth factor beta and bone morphogenic protein, which leads to bone growth. And that's where you get the osteophytosis, the development of these bone spurs, which further derange the architecture of the joint and further piss off the synovium, right? So, what we see here is that we don't have a simple wear and tear mechanical process. We have a highly elaborate biological process taking place at several levels of biological organization: histologic, the genetic, and the cell signaling level, right? So this process feeds on itself over time and accelerates and is progressive. And a lot of these processes go in both directions. So you've got vicious circles forming, and there's a lot of crosstalk between different parts of this process. So this is actually a very complex disease. It's not merely a mechanical disease. Now, we said that there were some other factors which could also result in the release of these evil signaling molecules and complement and so forth into the synovial. So what are these other factors? Well, these other factors include the metabolic syndrome, insulin resistance, obesity, a sedentary lifestyle, frailty and disuse, and chronic systemic inflammation from any source, right? So we've heard about those things. In fact, there's a certain shorthand I use for this constellation of features. I call it the sick aging phenotype. Very interesting that it feeds directly into the development of degenerative joint disease. So that's osteoarthritis, an extremely complex disease of the joint organ. Rheumatoid arthritis, also extremely complex disease of the joint organ. Common, but less common than OA, affecting maybe at most 1% of the general population, but that's growing. Onset in middle age, affects females more than males, and it is a systemic disease. It's not strictly a joint disease. It has impacts on almost every organ system. Pretty horrifying disease, actually. How does it happen? We're not entirely sure, but it's some connection between the genetics and the environment and lifestyle, and we'll look at that in a moment. Any joint can be affected, but it's particularly devastating to the hands, the feet, and the cervical spine. It can affect the knees as well. It presents with pain, swelling, stiffness, systemic symptoms, lung symptoms, increased pain, fever, and disfigurement, of which you can see an example here. This is the classic ulnar deviation of the digits in rheumatoid arthritis. Whenever you see an old person and they've got their fingers sort of like pointing out to the side like that, that person has rheumatoid arthritis. And you can see this bony destruction here in the finger, right? Very classic for rheumatoid arthritis. And it's that bony destruction that allows the joints to sort of like come off themselves and deviate over to the side in the hands. Devastating. What's going on here? Well, to simplify quite a bit, what's going on here is that you have some combination of, sorry about that, I don't know why that's there. You have some combination of genetic environmental factors. A particular major histocompatibility complex type, genetic tissue type that you inherit, you have the wrong parents, right, predisposes you to the development of disease. You combine that with certain environmental factors, maybe a microbial component. There are certain forms of infection which have been linked to the onset of rheumatoid arthritis, and smoking. Smoking is evil. So if you have a genetic predisposition to rheumatoid arthritis and you smoke, well, then you sort of deserve what's going to happen to you, right? And what's going to happen to you is this process of autoantigen modification. It's not clear to me that we know exactly how this happens, but what it basically is a transformation of some of your proteins in a way that makes them immunogenic. And the classic example here is what's called citrullination, where a particular amino acid, arginine, is somehow transformed into citrulline. And this can happen in various proteins, including vimentin and collagen. And this leads to the formation of a new autoantigen, right? So this protein has been changed. And because of your particular tissue type that you inherited, you now become allergic to that particular protein, right? That has been altered by this process. And so antigen-presenting cells of the immune system now recognize that protein as foreign, and an immune response is elicited. This results in the translocation of various immune cells to the synovial fluid, and fuckery ensues, right? T cells release inflammatory cytokines, tumor necrosis factor alpha, interferons, and so forth. Beta cells, or plasmacytes, release autoantibodies, antibodies directed against you, right? And these include the rheumatoid factor antibody, which tends to cause these immune complexes, these sort of glops of immune proteins and immunoglobulins, and antibody against citrullinated proteins, like the citrullinated collagen in your joint, right? And neutrophils are white blood cells show up and release toxic components like free radicals, reactive oxygen species. All of this results in inflammation. Inflammation of the synovial fluid, inflammation of the cartilage, and inflammation of the synovium. In fact, the synovial membrane just loses its fucking mind at this point. And it becomes almost sort of a neoplastic tissue, incredibly hypertrophic, incredibly hyperplastic. It grows out of control. It's almost acting like a sarcoma, like almost sort of like a cancerous tissue. And it puts out little projections in villi. Will show you one of these pictures. It looks, if you look at an endoscopic picture of the pannus, of the synovial pannus in rheumatoid arthritis, it looks very similar to what I've seen at endoscopy when you're doing an endoscopy on somebody who has a colorectal cancer. It has that same sort of fungating, fibrillated look. So it looks almost like a cancerous tissue, and it erodes cartilage and bone and leads to joint destruction. Once again, you have the elicitation of these various damaging factors like rank L, which can lead to bony destruction, and these inflammatory components in the joint, because the pannus is so heavily vascularized, they can get into the systemic circulation. So rheumatoid arthritis can start in the joint, but it becomes systemic. This gross oversimplification brought to you by the Starting Strength Coaches Association. So, that's what's going on in rheumatoid arthritis. There are other arthritides and arthropathies. Because we're short on time, I'm not going to go into these in any detail. This last part of my presentation should serve as a guide to self-study. But in particular, ankylosing spondylitis is a particularly cruel disease. Reactive arthritis, that's the Reiter's syndrome. The arthritis, urethritis, conjunctivitis, can't see, can't pee, can't climb a tree syndrome. The Ehlers-Danlos, I'm Gumby-Dammit syndrome with the people with the hypermobile joints, the very elastic tissues, turns out not to be such a great thing. Lupus is well known for having an arthritic component, psoriatic arthritis, and others. Oh, and your clients with inflammatory bowel disease, all right, ulcerative colitis or Crohn's, they will have an attendant arthritic component to their disease as well. Septic arthritis is basically when your joint becomes a petri dish. I've got some information on here about the various microorganisms. Basically, when you're young, a young person with a new monoarticular arthritis and effusion, what is the first thing I think? Angie, she here? What's the first thing you think? Gonococcus, right? You think VD. Young person, new joint effusion, you think venereal disease. You think gonococcus. Over 50, obviously, people over 50 don't have sex, so you don't think about men, right? What you think about is other microorganisms and then. But the point of this whole slide is this, really. You can't blow off a new monoarticular arthritis, right? A patient, especially a young patient with a new monoarticular arthritis, that person should not be working out in the gym. That person should be in the ER with a needle in their joint so we can look at the fluid and make sure that their joint isn't turning to pus right before our eyes. A gonococcal septic arthritis will destroy a synovial joint within 24 hours, right? So, new monoarticular arthritis, or for that matter, a new polyarticular arthritis, new arthritic symptoms means referral, because some of these processes can be fulminant and quite destructive. Hemarthrosis is a fancy word that means blood in the joint, and obviously that can go along with trauma, but also with bleeding diatheses like hemophilia. I personally would probably not train a client with hemophilia, right? Hemarthrosis is bad. One of the great educators in emergency medicine, Rick Bucata, likes to say that when blood meets cartilage, cartilage loses, right? Cartilage is very, very bad. Blood is very, very bad for cartilage, and I always advocated for these patients, especially young, active patients, to get arthrocentesis for removal of blood, particularly from the hip, knee, and shoulder, the three joints that we're talking about today. So, somebody has a joint injury and the joint swells up, you've got to consider that they may have a hemarthrosis, and who knows, if you refer them, maybe some enterprising physician will actually remove the blood from the joint and do that patient a big favor. The crystal arthropathies, I always think of these like the Henry VIII guy who eats a lot of meat and drinks a lot of wine and doesn't get any exercise except with Anne Boleyn and her sisters. And so what does he do? He develops this crystal arthropathy, which is the deposition of uric acid crystals in the synovial joint, right? And these crystals are long needle-like crystals that literally impale white blood cells. So when you look at the joint fluid on the microscope, you see this classic appearance of what are called the wimpy burgers. They look like little hamburgers because the joint crystal is literally impaling, you can see it, literally impaling the white blood cell, and that leads to this profound inflammatory response. Pseudo-gout is different. It's calcium pyrophosphate deposition disease, but they can both lead to very painful arthritic conditions and limitations. They're treated with diet and, in the case of gout, with allopurinol, which is a xanthine oxidase inhibitor. We're going to finish up a little bit here with tendinopathy, and this is what I want you to take away from today's lecture about tendinopathy. Tendinopathy is a continuum of histologic changes in the tendon. Our current thinking about this has been very strongly influenced by the work of Cook and Purdom. They put forward this continuum model of tendinopathy in 2008, and since then there's been continuing evidence to support it. Basically, it goes like this. Under normal conditions with a normal tendon, which undergoes normal loading because you're such a careful coach, right? And you're doing excellent programming for your clients, the tendon is basically part of the stress recovery adaptation cycle, and it undergoes adaptation at the ultrastructural level to tolerate new loads. And so you see these collagen fibers, which are closely packed and all appropriate. But if the load is unfamiliar or inappropriate, you can get a condition called reactive tendinopathy, in which the space between the collagen fibers becomes filled with proteoglycans and with water, right? So the tendon will swell up. It hasn't undergone any ultrastructural remodeling, and it's not undergoing a hypertrophic response, but it is bigger and thicker. In other words, its cross-sectional surface area has increased, right? And just like within muscle, right, when you increase the cross-sectional surface area, you increase its strength, right? So it's a way for the tendon to sort of like cover its bases while it's trying to heal up from an inappropriate load. If the load is not removed, right, or if the process goes on, you can get into a state of what's called tendon disrepair. Now the collagen fibers are becoming increasingly disorganized. Some of them are damaged. You have some neovascularization going on. You have different types of collagen coming into the tissue instead of the collagen that you want. You have different types like collagen 3 coming in. And the tendon is relatively disorganized. But up until now, this process is completely reversible. You can go from a state of tendon disrepair back to normal tendon, assuming that the tendon is appropriately unloaded, but not completely unloaded, right? And you can get back to normal tendon. However, if the damage continues, you'll get to a condition in which you basically have a huge gaposis within the tendon. It becomes acellular. There's nothing left but this non-living, disorganized matrix. This is called degenerative tendinopathy, and it's like the black hole of the tendon. Once you cross over into degenerative tendinopathy, you aren't going back. That part of the tendon will no longer remodel, right? It will not heal. It will not go back to normal tendon, right? This process can also be initiated by unloading of the tendon, what's called a stress-shielded tendon. Basically, a tendon that isn't getting used enough, right? There, normal activities of daily living and certainly excessive loading can launch that stress-shielded tendon directly into this pathologic pathway, right? So you don't want to over-unload the tendon as well. The tendon has to be used. The end stage of this process is either rupture, chronic pain and dysfunction, or return to function. Well, how can that be? You just told us that this degenerative tendinopathy is irreversible. That's right. But Cook herself, who put forward this model, has gone on to demonstrate that this histopathology does not correlate with function. So what we see is that we can get a tendon that behaves well, functions well, allows the athlete to continue training and performing, even though you have these islands of degenerative tendinopathy within the tendon. So Cook talks about what's called this donut hole model of tendinopathy, where you have islands of tendon that are degenerative, they're not coming back, right? But you can train the tendon around it and make that tendon stronger. Here I've shown it being a little bit more hypertrophic. It's not really a hypertrophic response, it's happening at the level of the ultrastructure of the tissue. And so in this donut hole model, the histopathology does not correlate with the tendon prognosis, and that's critical. And it also puts into perspective this tendency for certain people to go in and say, well, what we need to do is we need to go and scrape out that degenerative tendon, right? We need to go in and scrape it out and get rid of that tissue. I think that this new way of thinking about tendinopathy puts that in a pretty unfavorable light. Finally, Cook herself is on record as saying that tendon adaptation and healing is much more strongly driven by explosive or plyometric athletic movements that rapidly load and unload the tendon and call upon the elastic properties of the tendon in performance, right? That's critical. And so for you haters out there, and you know who you are, right? I'm just going to leave that right there, okay?